Hello, everyone, and welcome to today's webinar titled Let's Get Back on Track, Perspectives from Brazil, Nigeria, South Africa, and Uganda on Achieving 2030 UNAIDS Goals. This webinar is a part of the 13th Annual Clinical Diagnostics and Research Virtual Event. I am Antonina Salcido of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and sponsored by Thermo Fisher Scientific. For more information about Thermo Fisher Scientific, please go to thermofisher.com. Now let's get started. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to first participate by communicating with other attendees using our new live chat feature during the presentation. You can find the live chat located at the left of your screen. You can also participate by submitting as many questions as you would like during the presentation. To do so, simply type them into the Ask a Question box and click Submit. You will also notice that the speakers have provided a survey located to the right of the Ask a Question box. This survey will be available during both the live session and the on-demand period. If you have trouble seeing or hearing the presentation, click on the Help Desk button located at the top of your screen within the navigation bar or from the lobby. Finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on the Continuing Education Credits link located in the Abstract tab from the menu at the left of your screen and follow the process to obtain your credits. I now present our panel of speakers. Dr. Carlos Brites, Professor of Infectious Diseases at the School of Medicine at UFBA, Olabanjo Ogunshola, Associate Director and Head of the Prevention and Community Directorate, Dr. Mandisa Dukache, Founder and Director of HIV Survivors and Partners Network, Dr. Sisi Kitio Mutaluza, Executive Director at the Joint Clinical Research Center, and Obiageli Okafar, Senior Manager of Product Applications at Thermo Fisher Scientific. For a complete biography on our speakers, please visit the Presenter tab from the menu at the left of your screen. Welcome, panelists. You may now begin your presentation.
Welcome, everybody. My name is Obiageli Okafar, and I am a Senior Manager for Program Applications at Thermo Fisher Scientific. So we all know that we're still emerging from the COVID-19 pandemic, and its impact on all areas of life and health is still being felt around the world. So today we'll discuss the impact of the pandemic on HIV care and treatment and how we can get back on track to achieving the UNAIDS 2030 targets. We'll hear perspectives from Brazil, from Nigeria, South Africa, and from Uganda. So just before we go ahead, I will just remind everyone about the UNAIDS targets and how we got here today. In 2016, countries around the world agreed to achieve or to work towards the fast track targets of 90-90-90 by 2020. And this meant that by 2020, 90% of people living with HIV would know their status. 90% of those who were diagnosed with HIV infection would receive sustained antiretroviral therapy. And 90% of those who are receiving antiretroviral therapy would achieve viral suppression. In addition to that, there will be 500,000 fewer infections, fewer new HIV infections, as well as zero discrimination. So the 2020 targets were a preamble to the 2030 targets, and the 2030 target was to end the epidemic of HIV/AIDS as part of the UNAIDS, the Sustainable Development Goals, specifically Goal 3. So if we look at where we are today globally in terms of our progress towards this target, we would remember that COVID-19 began at the end of 2019, and by the end of 2020, these were the progress that the world had made in terms of the 1990 targets, and we see that we missed this 2020-1990 targets, where 84% of people living with HIV knew their status by 2020, and this left more than 27% of people living with HIV who were not on treatment, and roughly about a third with unsuppressed viral loads. And UNAIDS report says that these gaps are even larger for subpopulations of children, young people, and men. So today we're going to hear from 4 speakers who are representatives of their countries, and they're going to talk about the impact of the pandemic on this 1990 target and HIV drug resistance in their countries and in their regions. They're going to tell us about some practices that were implemented to deal with the disruption of care and treatment during the pandemic. And we'll also discuss some key transferable lessons that were learned in these countries. And as countries look beyond COVID-19 towards achieving the 95, 95, 95, 2030 targets, what can be done and what can be adopted across the world. And just disclose that all speakers participating in today's symposium were provided an honorarium by Thermo Fisher for their participation today. And without further ado, I'll introduce the speakers to us today. And we're going to be hearing first from Professor Carlos Brites. Dr. Brites is a professor of infectious diseases at the School of Medicine at Federal University of Bahia in Brazil. Dr. Brites has been involved in several clinical trials in HIV and has co-authored over 190 scientific papers. He was the editor-in-chief of the Brazilian Journal of Infectious Diseases from 2009 to 2016, and he's an editorial board member of Current HIV Research Journal. And so without further ado, I invite Professor Carlos to give us his presentation.
Thank you, Obi. May I have the next slide, please?
Sure.
First, I thank the organizers for the opportunity to share some data on the impact of COVID-19 on HIV care in Brazil. This is my conflict of interest. Next, please. I will start the presentation showing that the number of people living with HIV linked to care increased from 2019 to 2021, as you can see in the right side of the slide. However, the number of dispensation, the number of drugs delivered for such patients decreased in the same period of time from almost 5 million doses to about below 4 million doses. It is probably an impact of the COVID pandemic, making some people unable to take the medication, to go to the pharmacy to refill the prescription. And on the right, in the left side, you can see the number of COVID in Brazil. We had over 30 million cases with over 664,000 people dead. And it means an incidence per 100,000 of 14.5. Next, please. And next slide, please. One way to look at the numbers and see how the pandemic affect the HIV care, excuse me, one slide behind, is to evaluating the number of tests that were performed for follow-up of HIV patients. The slide before this would show, yes. Here you can see in the upside of the slide the number of CD4 cells count performed during the pandemic. And you can see in the dark blue, a sharp decrease in the number of tests performed from April 2020 until the end of the year. And the same could be observed for viral load, HIV viral load performed in Brazil that year. We see that in 2020, there was a partial recovery of the numbers, but the numbers still are below that observed in 2019. Next one, please. Next slide, please. It seems there is a delay. Yeah. This picture shows the number of people starting antiretroviral therapy during the pandemic period. And again, we see in the dark blue a sharp decrease in the number of people starting antiretroviral therapy if you compare 2020 to 2019. And again, a slight recovery of the numbers in 2021, but they are still below that observed in 2019 and pre-pandemic period. Next, please. And this impact can be also observed in the number of new HIV cases reported by the Brazilian Ministry of Health over time. We see a decrease in the number from 2017 to 2019, but it is more marked from 2019 to 2020. If you expand the numbers observed in 2021 up to the June, we see that it will give us a total of about 8,000 people, new cases diagnosed in that period of time, which means half of those observed and detected in 2018, 2019. It means a potential impact on the first 90 to 95 target UNAIDS because the number of new cases are decreasing over time. Next slide, please. We can see also another effect of the pandemic in the delay in artery refill in patients comparing the pre-pandemic and during the pandemic period. In 2019, only 14% of people on antiretroviral therapy had a delay higher than 30 days in receiving the antiretroviral drugs. In 2020, there was an increase in 25% in this number. It means that 18% of people living with HIV on antiretroviral therapy had a delay higher than 30 days in refilling the antiretroviral drugs. Next slide, please. This can show one way the Brazilian Ministry of Health tried to minimize this problem. At the beginning, before the pandemic period, we had most of the people, 72%, had a refill of antiretroviral drugs up to 30 days. And then it was increased to almost 60%. And in 2021, only 40% of people took the antiretroviral drugs for a shorter period of time. Most of them received for 2 or 3 months. It means less need to go to the health service to take the drugs, and would improve the adherence of people to therapy. Next time, please. Next slide, please. The same profile, the same pattern of decrease in the number of cases we can see for PrEP and post-exposure prophylaxis dispensing during pandemic. We see again that 2020 was the most affected year, and there is a coincidence of the peak of the case you can see in the figure below, and the sharper decrease in the number of people taking drugs for prevention during that period of time. Next, please. Here we can see the proportion of people starting therapy with CD4 count over 500 cells and the proportion of viral suppression. Regarding the number of people starting therapy early in the course of disease, there was a stability over time. And we can see the same in the proportion of people on antiretroviral therapy presenting with viral suppression, except for a decrease that is perceivable from 2020 to 2021 among women. We know that women are more vulnerable and they have more problems on adherence to therapy, and it seems that the pandemic affected in an unequal way men and women regarding virus suppression. Next slide, please. The adherence, however, seems to be on the rise in the last 3 years. You can see that from 2019 to 2021, the numbers show an increase in the adherence rate, as well as the loss to follow-up was decreasing over time. And we can see that according to the official data, the proportion of patients with adequate adherence was higher in the last 3 years. Next, please. Next slide. Here we can see the proportion of people lost to follow-up by year and sex. And again, we have an instability from 2020 and 2019 and 2021, showing that probably the impact of the pandemic on this specific aspect were not that important, at least for on the official data. Next slide, please. We can see also the same pattern, retention and care by sex and age, and then over time. From 2016 to 2019, we have an increase in retention and care, and for women and men, and in general population living with HIV, and it is stable in 2020. We have no data from 2021, but probably there is no significant change in this period of time. Next slide, please. Here, we try to see, to evaluate how the pandemic affect our patients in our AIDS clinic. And here we can see that the first case of COVID was detected in February 2020 in Bahia. So we have an increase, a peak of missing medical visit in the next 2 or 3 months. And again, it decreased over time, but it still remained high until November, when the number of the pandemic became lesser than in the previous months. And in 2021, we have an oscillation. But again, when the pandemic peaks in August, September, we have an increase in the number of the proportion of patients missing medical visit, which of course has a direct impact on adherence in such population. Next slide, please. We try to look at the reasons for missing scheduled medical visit, and almost 40% of patients reported missing medical visit during pandemic period. And the main reason for doing that was fear of COVID contamination. 2/3 of patients did not show up because they are afraid of contamination by COVID in this period of pandemic. Next slide, please. Some additional findings. We noted an increase in the number of missing medical visits in the first months of 2021-22, not captured by official report yet, as well as an increase in the number of adherent patients that stopped therapy during COVID-19 related factors, especially difficult to move to the pharmacy. A sharp decrease in the number of new AIDS cases from 2019 to 2022. And we believe that there is not a same pattern across the country. We probably have very marked difference between sites in big cities and small cities and undeveloped regions. And we have heard from colleagues from other cities and regions that the situation can be much more significantly affected by COVID. The adherence, the medical visits, and probably in different places of the country, there is different this situation. It means that we do not know yet the impact on the HIV resistance because there is no data on that, but probably will be significant and will appear in the next few months or next few years. Next slide, please. And as a sort of conclusion we can take from this data, according to the official data, the adherence pattern to antiretroviral therapy was not significantly changed during the pandemic. But we believe that the increase in the drug supply duration was an important tool to minimize adherence problems. However, missing medical visits were clearly associated with the peaks of COVID-19 pandemic, especially in the first year of COVID. And to date, we have no way to measure the impact of pandemic and consequent increase in frequency of missing visits on adherence and on emergence of viral resistance. We believe that we will need more investigation, more deeper investigation that at the national level to know exactly how was the impact of this pandemic on all these markers of HIV care, and specifically on the UNAIDS target for 2030. Thank you for your attention.
So thank you so much, Professor Carlos, for that presentation. And right now we'll move to our second speaker, Dr. Olabanjo Ogunshola. Dr. Ogunshola is the Associate Director and Head of Prevention and Community Directorate at APIN Public Health Initiative. APIN Public Health Initiative is a PEPFAR implementing partner in Nigeria, and in Dr. Ogunshola's role as the Head of Prevention and Community Directorate, he provides technical and strategic leadership for HIV program implementation activities across several states and locations in Nigeria. And so right now I'll hand over to Dr. Ogunshola for his presentation.
Yeah, thank you, Dr. Obi, and thank you, Professor Carlos, for sharing the perspective from Brazil. So I'll be sharing the impact of COVID-19 pandemic on the UNAIDS 95-95 in Nigerian program experience. Next slide, please. I would like to declare conflict of interest disclosure that I was given an honorarium for this. So despite the COVID-19 pandemic, Nigeria made progress towards the UNAIDS 95-95 goal. In 2018, Nigeria was at 67, 53, 42%, looking at the 95-95. And in the year 2020, we moved to 90% for the first 95, 86 for the second, and 72 for the third 95. So if you look at this, despite the pandemic in the year 2019 and 2020, we made progress. Next slide, please. So the COVID-19 pandemic story in Nigeria, the first case of COVID-19 pandemic was on 27th February 2020. And within a short period, it spread across all states in the country. As of 26 April 2022, Nigeria has tested over 5 million with over 250 confirmed cases. And the case fatality rate in Nigeria is about 1.2%. Next slide, please. With the advent of COVID-19 vaccine, Nigeria has partially vaccinated 20% of the eligible clients and has fully vaccinated 13.3% as of April 2024, 2022. Next slide, please. The COVID-19 pandemic in Nigeria triggered massive contraction in client volume in health facilities, and this also had an impact on the HIV case finding and retention on treatment. If you look at the figure here, this is just showing experiences from 2 states in Nigeria. At the scare of COVID-19 in February 2020, there was a plunge in the number of new cases identified for HIV and in the number of positives to identified. And of course, there were a population-wide anxiety and concern, and there were structural lockdown in the country in which movements were restricted and even facilities were only offering emergency services. Next slide, please. However, what was the experience and impact? For us in the APIN Public Health Initiative, we are a PEPFAR implementing partner, and currently 1 in every 5 people living with HIV in Nigeria are receiving care in our supported facilities. Next slide, please. So looking at the first 95, in the year 2018, Nigeria conducted the National AIDS Indicator and Impact Survey, and that actually brought to the fore the current status of HIV infection in Nigeria and how the program needs to move forward. And there comes COVID-19 pandemic in 2019. For the first 95, there was a shift to the community to deepen HIV case finding. Prior to this, more efforts were concentrated in the facilities. So if you look in our program, you'll see a gradual increase in the proportion of HIV testing done in the community. Next slide. And this is showing, comparing the yields from the facility testing and the community. And if we look at when COVID-19 was at its peak, a lot of efforts were in the community, and community was actually yielding quite a high number of HIV positive. You can see that at a certain time, we were at 8%, 9% positivity yield. However, as things is up, it dovetailed down to meet the facility testing yielding numbers. Next slide. So what strategies are being implemented at the facility or in the community? Well, the country is implementing risk-based testing using the risk stratification tool, and that has really improved testing efficiency and also improved yield from testing. So we are more efficient in the use of resources. Then we've also intensified index testing, both at the facility and the community, and the use of data, recently HeatMap, to target location of active transmission to improve HIV case detection. Next slide. Now looking at the second 95, issues about retention and treatment. In our program, if we look at a trend analysis as shown here, between October 2018 and September 2021, you can see that we had more people on treatment living with HIV, despite the COVID-19 pandemic. Next slide. And one of the strategies to keep more people on treatment is the multi-month dispensing. So this figure is showing that as we move during the pandemic, there were more PLHIV who are placed on 6-month drug. That means they have drugs they can use for 6 months at home, and the impact of restriction in movement, structural lockdown will have minimal impact on them, and hence they are retained on treatment and they're able to achieve viral suppression. Next slide, please. So for us to optimize retention, key strategies is to work with the community, with the network of people living with HIV, then to implement case management team structure, and to reduce interruption in treatment. This has really worked. Then, of course, the differentiated service delivery, in which people are at the center of the services they are receiving. So services are taken to people where it's convenient, and this has helped them to be retained in care. Next slide, please. Now, looking at the third 95, ensuring viral load coverage and suppression. The COVID-19 pandemic had impact on commodity logistics and lab operations. The key issues were inter and intra-state movement restriction. There were also delay in shipments of commodities reagents due to flight disruption, commodity shortage due to production cut by vendors, and this actually had impact on after 95. There were stock out of PCR commodities, and there were also prolonged turnaround time for sample movement and results return, which also accumulation of samples, backlog of samples, because there are no reagents and commodity to process them. And there are also delay in access of engineers to come out to site to resolve equipment faults. But what are the interventions that were put in place? There are sample routing to mega labs. Results were returned using courier services. And there was the activation of the laboratory information management system, which is an electronic method of downloading results at the facility. So the results don't need to move from the lab to the facility. Next slide. And this intervention actually yielded results that despite the COVID-19 pandemic, in our program, we can see a progressive increase in viral load coverage and suppression, even during the pandemic. If you look at 2019, 2020, if you compare, you can see there's a steady progress in viral load coverage and suppression. And at the end of Q1 2022, we've achieved viral load coverage and suppression of 95%. Next slide, please. So what are the strategies put in place to achieve 95% viral load coverage and suppression? One, we can liken it under this three category: the pre-tracking intervention, the tracking intervention, and the post-tracking intervention. The pre-tracking intervention has to do with educating the patients and deploying viral load champions as gatekeepers at the entry and exit point. Then the generating line listing of active clients will require viral load bleeding. And the tracking interventions involve using of peer, the case management team, the facility tracking team, institutionalizing cluster bleeding in outreach communities, so that even bleeding for viral load can be done in the communities. We don't actually need to wait for them to come to the facilities. And the post-tracking intervention is the use of the laboratory information management system, which has helped to reduce the turnaround time from results getting from the lab to the facility. Next slide, please. So what are the key lessons learned that relates to the impact of COVID-19 on HIV programming? One, we've learned that integrating routine vaccination services into ART services have helped to improve vaccination coverage, and it has also helped to improve HIV case identification. Then that differentiated service delivery is the way to go, because this has helped to improve patient outcome in terms of retention, in terms of viral load coverage, in terms of viral load suppression. And the use of technology, phone call, WhatsApp group, SMS, has helped to improve patient monitoring. We've also learned that multi-month dispensing is key to improving retention and suppression. Then for the healthcare workers, we've learned that the virtual platform is a good tool to build capacity of healthcare workers, and that the COVID-19 pandemic has overall improved the standard safety precaution and hygiene of health facilities and of our healthcare workers. Next slide. This good result or mitigation of the impact of COVID-19 on the UNAIDS 95-95-95 was done in collaboration and support from different stakeholders: the funding agency, PEPFAR, the network of people living with HIV/AIDS in Nigeria, implementing partners like APIN, the government of Nigeria, the community itself, Global Fund, and of course, we need to thank the healthcare workers who have worked tirelessly during this period to provide services to our patients. Next slide. Thank you so much.
Thank you so much, Dr. Ogunshola. Without further ado, I will go ahead and introduce our next speaker. Our next speaker is Mandisa Dukashe. Mandisa is the founder and director of HIV Survivors and Partners Network in South Africa. And for over 15 years, she has worked in the field of HIV program design, management, and system strengthening. She is a U=U pioneer in South Africa and a co-founder of U=U Africa Forum. U=U is a movement that is led by people living with HIV across 9 African countries. Mandisa is also a member of several key advisory boards on HIV prevention and control. And so we welcome Mandisa to give us her presentation.
Thank you so much, Obi. I want to declare that I received an honorarium to be a speaker and I don't have any conflict of interest. And I'll be presenting. The overview is COVID-19 impact on HIV services, human resource and infrastructure, the UNAIDS 1990 progress. I think during the opening, Obi did highlight on what 1990 are. And I'll also talk about data before and after COVID, HIV drug resistance. Next slide, please. The pandemic mainly impacted HIV educational testing programs and the provision of protection methods, especially during lockdown, because people could not travel to access the services, and that most of the services are happening in communities. In South Africa, ARV provision was generally maintained during the 2020 COVID-19 lockdown. And what also helped is the decanting or decentralization of HIV services, especially ARVs provision, because people collected ARVs in communities. They did not have to go to facilities. But HIV testing, which is mostly community-based, home-based, it was severely affected. And ARV initiation were heavily impacted as well. In other countries like Kenya and Nigeria, up to 50% of people with HIV could not have their ARVs supplies. Next slide, please. And when it comes to human resource, commodities and infrastructure, health facilities experienced staff shortages when facing the surge of COVID-19. So the situation was further complicated by staff absenteeism. Health workers were very sick because of COVID, because as we know that they were first line workers during the COVID-19 pandemic, and some had to quarantine because of exposure to the virus. And in total, 67% of facilities across Africa were affected. And there were spot checks that were done in health facilities, and data proved that 24 countries in Africa and only 38 of health facilities had protective material, that is masks, disinfectant, gloves, and hand sanitizers, and across all health workers. And only 61% had surgical masks. Remember, these people that we're talking about are frontliners, and they were engaging with patients on a daily basis. And only 8% of facilities across Africa could carry out a COVID-19 PCR tests, and 37% could refer samples. Some countries had to use HIV PCR machines to test for COVID. That is redirection of infrastructure and commodities. Next slide, please. What was the impact on the 1990 targets? I think, as I was saying, that we all know what the 1990 meant before COVID. And in the continent, or in Africa, Eastern and Southern Africa, as of 2020, 20.6 million people were living with HIV just before COVID. And out of the 20.6 million people with HIV, 72% of those people had access or were on ARVs or antiretrovirals. And of the 20.6 million people with HIV, 65% had viral suppression. I'm looking at the numbers below. I'm overlooking the one above, because if you look at those above, you may think that we succeeded and achieved, but interpretation of those is not looking at the total number of people that are living with HIV. That's why I'm concentrating on the numbers below. Next slide, please. So what was the scenario or the picture before COVID and after COVID? According to paper data, HIV tests before COVID per quarter was at 3.7 million, and that number decreased by close to 1 million after COVID to 2.7 million. And the positivity rate per quarter before COVID was at 164,000, and after COVID it decreased by close to 60,000. The numbers of people that tested positive for HIV. ARV initiation, it was 89%. We're close to achieving the 90 target. But post-COVID, that decreased by 60%, the decrease of 30%. And imagine this is data that was presented 2021. We don't know what's the issue and the situation now. So resources that were used for HIV that had to be redirected to COVID, PCR machine used for HIV viral load testing, enabled to rapid establishment of COVID to PCR testing, meaning a lot of activities or tests that were supposed to be done for HIV could not. And gene sequences platforms established for HIV resistance testing were used for variant identification, and clinical trial infrastructure for HIV vaccines pivoted to undertake COVID-19 vaccine trials. Next slide, please. So there was also a survey that was done by Human Research, Science Research Council in South Africa that discovered that 13% of people had no access to their chronic medication during lockdown. And the rapid assessment in Zambia in April 2020, just before COVID, I think it was a month after COVID was identified, find out that 90% of people with HIV attempting to get refill, it was the time where, lockdown, I think it was in level 5. Those people could not get a refill of their antiretrovirals. They could not actually access. Some had a partial refill of their treatment. And the government prioritized intervention to control the spread of SARS-CoV, and less effort was put into ensuring continuity of other health services, including delivery of HIV services. In May 2020, just 2 months after identification of COVID, World Health Organization survey in 13 African countries discovered that there were a lot of stockouts, and especially with the first-line drugs, reason being including failure to supply. Remember, I think one of the speakers mentioned that the flight restrictions and and all that kind of thing really affected this particular supply. The next slide, please. So, I think there's a lot of data that proves that a majority or some people with HIV are developing drug resistance. And this one in particular was conducted in South Africa in 2017, and it discovered that more than a quarter, 27.4%, of virally unsuppressed respondents had viral resistance of HIV. So now lockdown happened, and we know there were a lot of gaps in terms of treatment access and all that. And some people could not have their viral load done, and drug resistance testing could not be done because infrastructure had to be used for COVID. So therefore, it's very clear that there will be more number of people increasing in developing drug resistance. So it is critical that the government recovery plan should be ramped up, and close monitoring of development of drug-resistant HIV should be a top priority. Routine viral load measurements should be a main focus. Efforts to increase access to routine HIV drug-resistant testing should be increased. This will enable more people. There was a break in my network. This will enable more rapid response to emerging resistant patterns and prevent increase in acquired drug-resistant cases, which were on the rise even before COVID. Next slide, please. So this is my last slide. So UNAIDS reported that COVID-19 pandemic had seriously impacted the AIDS response and could disrupt it more. I think it was before, the first year. So a 6 months complete disruption in HIV treatment could cause more than 500,000 additional deaths in the region over the next year, that is between 2021. bringing the region back to 2008 AIDS mortality level. Even a 20% disruption could cause an additional 110,000 deaths. So this is something that we really need to focus on as the region, because we need to mop up and look at them actually that go down to assessing the impact of COVID-19 and come up with mitigation plans. This is my last slide. Thank you so much for listening. Over to you, Obi.
Thank you so much, Mandisa. So I will go ahead and introduce our fourth speaker. Our fourth speaker is Dr. Cici Kitio Mutuluza. She's a public health specialist and epidemiologist with over 29 years of experience in HIV/AIDS care, treatment, and research. Dr. Kitio is among the pioneers of antiretroviral therapy in sub-Saharan Africa from 1992, and she has been at the forefront of scaling of care and treatment since 2003. Dr. Kitio is currently the Executive Director of the Joint Clinical Research Center in Kampala, Uganda. And so at this time, I will hand over to Dr. Cici Kitio for her presentation. Thank you.
I will talk about the state and role of HIV drug resistance testing for surveillance and patient management in Uganda and its relationship with achieving epidemic control in the country. This is my conflict of interest disclosure. So the wake-up call to address HIV drug resistance for patient management, especially in low and middle-income countries, only came after the HIV drug resistance World Health Organization report in 2017. And in this report, 6 of the 11 countries that had reported national HIV drug resistance survey data collected according to WHO guidelines had pre-treatment HIV drug resistance equal to or above 10%. And Uganda featured prominently among these countries, as can be shown here in blue. However, high levels of HIV drug resistance had already been detected in Uganda as part of the Pan-African studies to evaluate resistance, codenamed PESA, which were conducted across 13 clinical sites in 6 African countries, starting from 2009. So the highest HIV drug resistance rates were seen in Uganda, with NNRTI rates higher than 5% across 3 sites that participated in this survey. And these are the high levels that were shown from the sites in Uganda. The same surveillance was done in the pediatric populations at the same sites as the adult surveillance from 2010. And these are the sites as shown here. And this surveillance recruited 317 pediatric patients who had a viral load done every 6 months. And similar to the adult population, pre-treatment HIV drug resistance to NNRTIs, as shown in yellow here, was already above 5%. And in Mbale, this was the town shown in the previous slide, which is near the Kenya border. The resistance was even more than 10%. So the action taken to address the high HIV drug resistance to NNRTIs was the revised World Health Organization recommendations to use dolutegravir-based regimens in first and second line ART regimens. And these are excerpts from the WHO guidelines. Addressing the HIV drug resistance at that time and now impacts directly on the third 95 goal or target of UNAIDS of having viral suppression, which in turn prevents transmission of HIV. So Uganda, like all other countries, is working towards ending the HIV epidemic by addressing many facets of the HIV, but including controlling viral load and HIV drug resistance. So on the left-hand side, this graph shows that by 2020, how Uganda was doing. There's been a steady decline in new infections, in AIDS-related deaths, and all-cause mortality along people living with HIV. On the right-hand side, this is the projection that by 2020, if we continue to put all resources and efforts are better aligned, by 2023, we project to have HIV epidemic control attained. And this is when new infections are lower than all-cause mortality among people living with HIV. Again, the UNAIDS strategy to end the AIDS epidemic includes the third 95 target of viral suppression and viral load monitoring, which we are doing in the programs, is to detect early treatment failure and also development of HIV drug resistance. So despite COVID-19, in the last 2 years, Uganda has seen steady improvement in both viral load coverage and viral load suppression. As at the same time, we were seeing an increase in the transition of patients to dolutegravir-based regimens as per the WHO guidelines. This slide shows a snapshot of COVID-19 trends in Uganda from 2020. The country had 2 lockdowns, and between the 2 lockdowns, that totals 6 months out of the 15 months shown on this slide. It's inevitable, therefore, because this is about 40% of the total time shown on the graph, it is inevitable that there were possible disruptions in the gains made in the roadmap to ending the HIV epidemic, which was fairly on course. And this slide shows that compared to the pre-pandemic baseline, which is the red dotted line, we saw a decline in all categories of patients enrolling on ART as new entrants. And it can be seen from this slide that a lot of effort was being put on patients who were already enrolled on ART. So the numbers continued to increase even during 2020, 2021 when we had COVID, because of the several strategies and efforts put into place to ensure that patients access their treatment even during lockdown. However, a decline in the children accessing ART was seen, and traditionally, this is the age group with the biggest problem of adherence and possibility of developing HIV drug resistance. So this slide shows the viral load tests done and also viral load suppression. The viral load tests, as you can see, fluctuated a lot during the past 2 years, although viral load suppression among those tested is seen to increase. However, we don't know what is happening to those patients we can't reach to perform a viral load, whether in lockdown or not. Again, this slide, which is from PEPFAR, summarizes sustained viral suppression at 96%, with increasing numbers of patients starting dolutegravir-based regimens. And as shown in orange, there is emphasis and increasing multi-month dispensing to prevent ART interruptions and therefore sustain viral load suppression. So while the viral load suppression is high, we looked at HIV drug resistance prior to the national dolutegravir rollout in 2018 to establish a baseline of dolutegravir resistance and continue to monitor resistance so that we can inform the programs. And among the ART naive patients, as seen on the upper graph, the first-line failures on the lower graph, we did not see any resistance to dolutegravir, and this work was done in 2018. All the green bars shows that these patients were susceptible to dolutegravir. In the same study, we also did not see any resistance to dolutegravir in patients failing second-line ART, as all of them were on protease inhibitors-based ART. So patients who were failing on integrase-based regimen, and at the time we were using raltegravir, already showed high levels of resistance and cross-resistance actually to other integrase inhibitors which we were not using at the time, like dolutegravir. Yeah. So this slide is data from more recent work, actually done in 2022, after the rollout of dolutegravir. And we see we had participants with a wide range of ages, and in green, patients had been on treatment for varied time periods. And then from this graph, we saw that we had adolescents and children failing on first line, we had patients failing on second line, and also patients who were failing on third line. So as per the indication on the previous slide for testing, this drug resistance surveillance data is also used for patient management. So from this graph, we see that we have a fairly high level of resistance to raltegravir, which has been used for some time now in the country, especially for patients who need third line. And that resistance also shows that there is cross-resistance to cabotegravir and bictegravir, which have not been used in the country except under research settings, and the numbers that have taken it are very small. However, we see that resistance to dolutegravir is still low despite the rollout, but we need to continue to do surveillance and so that we can inform policy and also the program. So we are continuing to do HIV drug resistance surveillance, and 2 studies are planned. One of them is for patients on dolutegravir who are failing with a viral load above 1,000 copies. And this work is going to be done at the UVRI, while we are also looking at another study of patients failing on dolutegravir but with low level viremia of 200 to 999 copies per ml. And the goal is to maintain dolutegravir durability following the high pre-drug resistance that the country experienced with NNRTIs, but also to detect drug resistance mutations to dolutegravir as early as possible and inform the ART program. So in summary, there is evidence of increasing HIV drug resistance to dolutegravir from 2018 to present. as the drug is being scaled up for first and second line treatment. Although this resistance is still low at the moment. This may affect gains made in HIV programming even during COVID-19 epidemic. So preventing and then ongoing monitoring and responding to this HIV drug resistance is critical to maintaining the current achievements, especially viral suppression, improving patient outcomes, and guaranteeing long-term sustainability of care and treatment programs. Thank you for listening to me.
Thank you to our panelists for your time today and your important research. Before we go, I'd like to thank the audience for joining us today. I'd also like to thank our sponsor, Thermo Fisher Scientific, for sponsoring today's webinar. Questions submitted today and during the on-demand period will be addressed by the speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand for 2 years until November 9th, 2024. LabRoots will alert you via email when it's available for replay. And we encourage you to share that email with any one of your colleagues who may have missed today's live event. Until next time, goodbye.